apnea, and sinus problems, and now mouth breathing associated with premature orthodontia that should have been done much later in life. Okay? If you feel like your teeth are snagged up or snaggle-toothed, wait until your body grows enough to actually then, or has reached its full skeletal maturation. So my recommendation, if you're going to do orthodontia, do it after age 21. Chances are your teeth will be in alignment by that time. If the child has too many teeth, overcrowding or snaggle or snagged up teeth, okay, I recommend an appliance that you can research by a Dr. Singh. Dr. Singh is in Portland, Oregon. And Dr. Singh uses an appliance called an epigenetic appliance. This is not a palatal spacer. An epigenetic appliance actually is an appliance that allows the face to do just what it says. Epi is something as a stimulus, and genesis is formation or growth. It stimulates optimal growth or optimal DNA expression in the face. Remember, our ears, our nose, and our jaw and face continue to grow even after our bodies have reached skeletal maturation. That's why for us as guys, our ears keep getting bigger and our nose keep getting bigger as we age. It's the only thing that gets bigger, okay? Everything else is shrinking. If we look at that though, the whole facies is changing, which means then to squeeze things down prematurely doesn't allow everything in the endocrine system and the brain to function optimally. There's a dentist in Canada who's doing research right now that is showing the constriction of the cranium actually leads to impaired blood flow, and impaired blood flow leads to demise of the brain, which is demise of brain we call dementia. Okay? How many of you want to have dementia? How many of you like your kids to have dementia? Again, another interesting study I think that we'll be following the next few years of how many people have dementia related to premature squeezing down of the facies and extracting of excess teeth and squeezing down the whole cranial structure. Okay? Again, a responsibility I think that we need to do as research before we just go and put something on to make the kid look cute. Yeah, you looked ugly for 2 years. Big deal. We had something to laugh about, right? Love those pictures. It builds character, thank you. My mom's so good, she just let me keep building character, didn't she? Thanks, Mom. Okay, so Dr. Singh, epigenetic appliance, that's what we look for. That was a big sidetrack to TSH. So thyroid stimulating hormone. Sometimes we actually have to activate the pituitary. Pituitary has many functions. That's one of their primary functions. Okay? Again, when we look at restoring function, then we want to use supplementation, eliminate potential problems that will lead to then continued impaired function of thyroid, and the faster we can restore that function, then the better off the person responds. Right? Now, last thing I want to just give you as a take-home tonight is what are optimal numbers of thyroid? If we have a TSH and I'm getting a blood level, what should my TSH level actually be? So let me actually clear up the board so we have an area to be able to visualize this.
Now there's a basic T3, T4, but then you can go into further testing.
That's correct. Exactly right. So let's actually just put this in the center rather than up in the corner. So TSH is the most commonly ordered serum value when a person is medicated with a thyroid hormone. Why? When you have thyroid hormone in the system, it works by a negative feedback loop and tells the pituitary to stop producing. So if I'm medicated, I'm taking Synthroid or levothyroxine, the feedback loop says, hey, there's plenty of me, stop producing. And a lot of endocrinologists will only measure TSH, and as long as that TSH is below a certain value, it's okay, doesn't matter. Okay? We use the functional endocrinology levels, or National Endocrinology Society's levels of functional optimals, and TSH should be between 1.8 and 3.0. Okay? So your thyroid stimulating hormone levels should be between 1.8 and 3.0 when it comes back. T4 comes as a T4 total. This should be between 7 and 9. Okay? If it's greater than that, hyperthyroid. If it's under that, it's hypothyroid. Pretty easy. And then the one that's infrequently ordered is the actual hormone that's available to the cell in the peripheral tissues, T3 free. Okay? And this should be somewhere between 1.2 and 4.0. Some labs go to 4.2 and some labs keep this at 1.4. Okay? 1.2 to 4.0 is pretty ideal when we look at T3 free. Okay? What does that mean? What's the difference between free and T4 total? T3 free, in order for a thyroid hormone to get from the thyroid itself out to the cells through the bloodstream, it actually has to be carried on a little bus. In order for it to get off the bus, then, and delivered to the system, it has to become free. So the bus driver has to actually open the door and let these guys go out. Sometimes T3 is measured as T3 only. Well, that means it's still bound to the bus. So we may be measuring a hormone that's just circulating in the system. But if it never gets off the bus, then it's never been free to activate the cell or work at the cell. Okay? So we like to measure T3 free, T4 total, and TSH. Thyroid antibodies that we check whenever we suspect an autoimmunity or when we see an enlarged thyroid. We look at thyroid peroxidase antibody, which is abbreviated TPO antibody, okay? As well as thyroglobulin antibody, okay? TPO, thyroid peroxidase antibody. Thyroid peroxidase is an enzyme that actually uses peroxide to attach iodine to thyroglobulin, a protein, a thyroid protein, or thyroid protein. That then, if there's something that's actually attacking the enzyme that binds the iodine to the thyroid protein, which is TPO, then we see this impairment, and now we just see that there's no attachment of the iodine to the thyroid protein. All right? So giving more iodine, is that going to help or hinder? It definitely won't help if the enzyme's already being attacked. Okay? So we measure TPO antibody. Thyroglobulin antibody is then that which actually attaches the protein, or attacks the protein, the antibodies that attack the protein. So we measure these always. When somebody's on a thyroid medication, these should be measured always. Now, once they're measured and they test positive, they're always positive. Don't go back and think, oh, this came back, it's supposed to be less than 30 or 34, and now mine was at 188,000. There's one lady that I saw that was 188,000. That's astronomical. Okay? Greater, or it should be less than 34. Hers was 188,000. Very, very positive. To measure that again and again and again, once it's positive, it's positive, it's positive. It's just like when you had the chicken pox. If you're to measure your antibodies in your body now, you don't have active chicken pox, you have an antibody against chicken pox, it's still there. If you have antibodies against either of these proteins or both, you don't have to keep measuring it thinking, oh, well, I've been gluten-free or I've done everything the doctor asked, I better measure it again. If it's positive, it's positive, it's positive. All right? Do your best to stop that antibody from reacting and continue to attack by avoiding the things that trigger the attack. If it's in your diet, if it's in some chemical, if it's in some stressor, if it's in some GI parasite, don't keep that parasite around as a weight loss program. All right? For some people, oh yeah, I have a little Giardia, I know, but man, it does such a great job for my figure. Yes and no. It's robbing you in many ways. I think I saw a question. Anybody have a question? Okay.
So if you're on Synthroid, you know, because a lot of doctors will put people on Synthroid, I've heard once you've gone on it, you can't go off of it.
Okay.
So if you go on the stuff like you have your things here, if you go on it and you get things in check, can you go off that?
Okay, so 2 questions. Number 1, I'm hearing you ask, is Synthroid a medication that can be stopped? Synthroid is exactly what it says. It's not S-I-N, okay, it's not bad. It's syn means synthetic thyroid. It is not the same chemical as T4. It mimics T4. Okay? So is it converted in the system? Not very well. That's why so many people on Synthroid keep going up and up and up and up with little effect. So now they actually add Cytomel, which is prescription T3. Okay? Once you've been on those 2 medications, is it likely you can get off? If you have had an irradiated thyroid or had thyroid cancer and they actually removed your thyroid, you're going to need to be on something. Okay? The interesting thing is, some Armour thyroid and some thyroid medications actually have gluten in them, which was what triggers the thyroid autoimmunity, right? So sometimes we have to beware. All right? The other key is, though, and the question is, well, if I start supplements, is there a time when I'll be able to go off supplements? And the answer is, potentially. Okay? Yes, if the thyroid can function again without supplementation, meaning it doesn't need to be fed anymore. The body and what I'm eating and I've eliminated actually allow it to function optimally enough that I don't need it anymore. Or I can reduce the dose to where I still function optimally. Okay? When you get a TSH that comes back at 144, okay, should be between 1.8 and 3.0, and you get a thyroid stimulating hormone that comes back as 144, that's a big concern, right? That means your pituitary is screaming its lungs out and nobody's responding. Well, that's a thyroid cancer patient that we saw who actually had their thyroid removed. They were under-medicated, but they were using Synthroid, and the Synthroid wasn't converting it all in their system. And even though they were using a lot, it wasn't feeding back into that loop. Okay? So we have to look at each person individually. To just say, oh yeah, every thyroid needs this and every thyroid needs this, isn't true. These are gross generalizations when I talk about this. Okay? We have to look at every person again as an individual. Are there, though, some patterns that we see? Yes, very often, and we've reviewed those tonight. Does that answer your question? Okay, very good. Any other question, sir?
What are the reactions to look for if you're allergic to gluten?
Great question. The question is, what are some of the reactions that we look for in the body with gluten sensitivities? True celiac disease means gut impairment. Okay? So gassiness, bloating after eating wheat or after eating bread, diarrhea, bleeding stools, ulcerative colitis, or a diagnosis of irritable bowel syndrome or irritable bowel symptoms. Very, very common with gluten. What are non-classic celiac symptoms? Conditions where the skin actually erupts in a condition called dermatitis herpetiform. It looks like little watery blisters a lot of times that will itch, they'll pop, and they'll itch even more. Okay? We see it a lot of times on the hands and the feet. Oftentimes it will affect the arms and the thighs, and sometimes on the lower shins as well. Very severe cases on the abdomen and on the trunk. Okay? Often you'll see it on the extremities first. Other symptoms of gluten impairment or gluten signs, a craniofacial structure that actually has a loss of the thirds of the face. In essence, when we look at the face, okay, there should be a distance from the chin to the frenulum. So when we look right here below the nose, from the chin to the frenulum should be the same height as from this height to right between the bridge of the nose and the eyes, which should be the same height as the hair. Okay? So this height should be the same as this height, should be the same as this height. With people who have gluten intolerance, non-classic celiac is a greater craniofacial height. So the hairline is actually here, and I'm not talking about receding hairlines, okay? Talking about where my hairline used to be. This height will be greater than this height and this height. Okay?
So
Please.
does that mean like their face changes because of, or it?
Yes. The question is, does that mean that the face changes as they remain gluten intolerant and grow? A lot of times you'll see the 3, 4, 5-year-old will have these equal heights, and after the age of 5, that will actually progress. Okay? So early detection of gluten intolerance is actually essential to helping to reduce the risk of intolerances later on, or other autoimmune presentations later on. Okay? Joint pain, so arthritis, is often an indication of a gluten intolerance. We talked about cerebellar ataxia, wide gait or waddling gait, acne on the scalp or cranium, okay, or on the scalp hairlines. That can also be sometimes an indication of that. Menstrual acne can sometimes be also associated with gluten intolerance because it's actually an indication of GI impairment. Okay? Underweight and undernourished. When you see a child, you look at a bunch of 12-year-olds, and here's this group of 12-year-olds, 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 okay? That guy that looks like he's 8 or 7 still when he's 12 and 13, highly likely that he has a skeletal maturation failure due to some type of impaired digestion absorption. Okay, and you see it very, very commonly. That help you? Any other questions? Okay, very good, thank you.